Hello guys. So now coming to the second chapter of thorax, that is pulmonology. Okay, so we'll discuss about some of the anatomy and physiology of the thoracic pulmonology, and then we'll go on to the specifics of pathologies and all the medicine and surgeries with respect to lungs and pulmonology. Okay, so now beginning with a little bit of anatomy. So the cells that are present in the lungs are, so the alveolar cells, the club cells. Okay, so in alveolar cells there are two types, that is type 1 pneumocytes and the type 2 pneumocytes. Okay, so type 1 pneumocytes are the ones that are responsible for gaseous exchange. So this is what is called as alveoli. So then the second one is the surfactants. Okay, surfactant producers. Okay, these are the stem cell precursors. Okay, so the type 2 pneumocytes are the surfactant producers and the stem cell precursors. Okay, so there are also macrophages in the alveoli, which are helpful for phagocytosis. Okay, then there are helping cells that are called club cells, which are columnar secretory granules. Okay, so these degrade toxins and also help in production of surfactant components, that is lecithin, sphingomyelin and all these things. Okay, so let us see what is this surfactant. Okay, so basically a surfactant reduces the surface tension. Okay, surface tension of the alveoli. Okay, so when the surface tension is reduced, it makes the alveoli to expand. It helps in alveoli expansion. Okay, during inspiration. Okay, so this is the main action of surfactant. Okay, so the component is lecithin. Okay, then one more thing about surfactant is it begins its synthesis by 20 weeks of gestation. Okay, by 20 weeks of gestation the surfactant production begins, but it matures by 35 weeks. Okay, so that is why before 35 weeks, if a baby is born, we'll consider, right, before 37 weeks preterm babies. So that is why it won't be as much mature as it will be there in mature babies. Okay, so that is why we'll give the steroid therapy, so that the surfactant maturation might happen. And also if surfactant is not enough, we'll do something called as insure technique, right? So we had discussed in pediatrics, right? So this is the main thing. Okay, so that is the thing. Okay, then the thing is, it is detectable by 28 weeks. So please remember all these things. Okay, all three values are important. So synthesis by 20 weeks, maturation by 35 weeks, whereas detectable by 28 weeks. Okay, then the stem cells are the type 2 pneumocytes, I told you, right? Some stem cells, basal cells and the Clara cells. Okay, these are the stem cells of the lung. Okay, so type 2 pneumocytes, basal cells and the Clara cells. Okay, so this is what helps in regeneration if there is a damage. Okay, so this is some of the basics of cells that are present in lungs. Coming to respiratory centers, this is very important. Okay, so respiratory centers, the two respiratory centers in our body is medulla and pons. Okay, so in medulla there is pre-Botzinger complex, dorsal respiratory group and ventral respiratory group. Okay, what does this do? So pre-Botzinger complex maintains the, it is like a pacemaker. Okay, it is like SA node and AV node with respect to heart. Okay, it is like a pacemaker. Okay, then coming to dorsal respiratory group, it maintains the, activates the inspiration. Okay, so it basically activates the inspiration, dorsal respiratory group, whereas the ventral respiratory group is for active breathing. Okay, so it maintains the active breathing. Okay, coming to pons, there is pneumotaxic center and apneustic center. Okay, this basically stops the inspiration, pneumotoxic center, whereas apneustic center prolongs the inspiration. Okay, so these are the respiratory centers. Okay, so so there are substances that are helpful in the regulation, that is VIP and NANC will be helpful in bronchodilation, whereas substance P is helpful for bronchoconstriction. Okay, then one more extra edge point is alpha 1 antitrypsin protects the lung against inflammatory enzymes. Okay, so that is where the alpha 1 antitrypsin deficiency will cause the certain particular pathology. We'll discuss more about it. Okay, so that is why alpha 1 antitrypsin is very important. It protects the lung against inflammatory enzymes. Okay, so this is with respect to respiratory centers and regulation of it. Okay, So now coming to the specifics of anatomy. So please remember, trachea to alveoli there are 23 divisions. Okay, so 23 divisions meaning this is, if this is trachea, it starts dividing, right, all the bronchioles. Okay, so terminal bronchioles. So this is 23 divisions that is taking place. Okay, so that is basically the finally it will be having conducting zone and the final respiratory zone. Respiratory zone will be the alveoli, right? So alveoli and the terminal bronchioles will be the respiratory zone, whereas all the other divisions will be conducting zone. Okay, so trachea starts at the level of C6. Okay, at the level of C6 it starts, and at T4 level, okay, at the vertebral level of T4 it will bifurcate. Okay, so at C6 it begins. Okay, then at a T4 is where the bifurcation happens. Okay, please remember this. Okay, then one more extra point with respect to conducting zone is the dead space. Okay, so it is basically dead space, right? Here no conduction is happening. I mean here no respiration is happening, so that is why it is called as dead space. Okay, so there is no function of it, so that is where that is where dead space comes in. So it is almost equal to 150 ml. Okay, so please remember this 150 ml. How can we measure this? Is by single breath nitrogen test. Okay, so that is how we can measure it. Coming to muscles of respiration, there are primary muscles and accessory inspiratory muscles and accessory expiratory muscles. The primary muscle responsible for respiration is diaphragm and the external intercostal muscles. Okay, then the accessory muscles are for inspiration is scalene muscles, right next to the neck, right? It is a neck muscle. So this is helpful in inspiration, whereas for expiration it is the internal intercostal muscles and the abdominal muscles which will push the air out. Okay, so these are accessory expiratory muscles. So then now coming to specifics of physiology with respect to pulmonology. So spirometry, right, pulmonary function test is what we do. So basically please go through all the graphs, that is all the volumes and all. You should know those things. The important ones is FV1 by FVC. Okay, so the normal value of FV1 by FVC is 75 to 85%. Okay, so the reason why we need this is we can decide with what kind of disease the person is going through, whether it is obstructive disease or the restrictive disease the lung is having. Okay, so if it is, suppose if it is a obstructive disease, meaning the expiratory volume at the first second will be low. Okay, so FVV1 will be low. Okay, functional FVC will be normal, whereas FVV1 by V1 will be low. So that is why it is going to be less than 70%. Normally 75 to 80% will be there, FVV1 by FVC, whereas in obstructive disease it is going to be less than 70%. Whereas in restrictive, the FVN by FVC ratio will be normal. Please remember that. Okay, so this is just by seeing the spirometry only we can judge what kind of disease the lung is having. Okay, so this is how the spirometry graph would look like. Okay, obstructive disease, this is the normal thing, so it will be towards the left side. Okay, so left. Okay, a boat like structure will be obstructive disease, whereas in restrictive it will be right shifted. Okay, so similar to normal only, but the volume with respect to expiratory and inspiratory will be reduced. Okay, so that is restrictive. Okay, or to the right. Okay, restrictive will move to the right. Okay, remember in that way. Okay, then coming to hysteresis. Okay, so there are two words that I want you guys to remember, that is compliance and elasticity. Okay, compliance means it is the ability of the lung to expand. Okay, instead of that, remember it as delta V by delta P, meaning the change in volume to the change in pressure is known as compliance. Okay, the elasticity is the ability to normal size. Okay, so it is the ability to normalize the size of the heart. Okay, so elasticity, basically elastic work. Okay, so elastic work, what does it do? So basically if I pull this string, if this is a string, and if I pull this string, and if it comes back to its normal position, it is called as elasticity, right? So that is the elasticity of the lung. Okay, So please remember, with age, the elasticity decreases, whereas the compliance increases. Okay, so this is the thing I want you guys to remember. Okay, then this is the hysteresis graph. Okay, so please remember, this is the hysteresis graph. Okay, then coming to Laplace law, we also learned about Poiseuille's law, where it was pressure is inversely proportional to R, right, R to the power 4. This is Laplace law, where pressure is inversely proportional to 1 by inversely proportional to radius. Okay, so that means during inspiration the radius increases, right? Radius of the alveoli starts expanding, so that is where the pressure decreases. Okay, so pressure in the lungs starts decreasing. Okay, and the compliance, as I told you, right, delta V by delta P. Okay, so what does that mean? So during inspiration, as the pressure is decreasing, so there is reduced compliance, right? So it means that there is reduced effort that I need to put as the inspiration goes on. Okay, so that is what the reduction in compliance means. Okay, during inspiration, so reduction in compliance happens, whereas in expiration there is increased compliance. Okay, so there is increased amount of pressure that is needed to be put. Okay, so this is what hysteresis means. Okay, so that's it with respect to hysteresis. Okay, now we'll go on to the ventilation perfusion. Okay, ventilation perfusion and the zones of the lungs. Okay, so this is very important. Okay, this is previous year topic, please go through this. So there is something called as West's lung zones. Okay, so please remember the nomenclatures here. So capital A is the alveolar pressure, whereas the small a is the arterial pressure. Okay, then or it is basically the O2 concentration. Okay, so please leave the O2 concentration. Please remember it as alveolar pressure or the arterial pressure, that that is the gradient that we are looking at it. Okay, so at the top of the lung, so there are zones of the lung. Okay, so think of this as lung. There is zone 1, zone 2 and zone 3. Okay, so in zone 1, so there is increased alveolar pressure. Here the air is too much, right? So what happens is the alveoli will be expanded too much because air goes up, right? So it is going to be too much air here, and it is going to compress the artery. So that is why the arterial pressure is low as compared to the alveolar pressure. Alveolar pressure will be high. Okay, so that is what this thing means. Okay, see, alveolar pressure is high as compared to the arterial pressure. Okay, so that is at the top. Then coming to mid zone, here it is arterial pressure more than the alveolar pressure, right? So alveolar pressure will be more than the arterial pressure. Then coming to third zone, it is going to be arterial pressure more than the venous pressure, more than the alveolar pressure. Okay, so here at the base, the alveolar pressure is quite very less as compared to the arterial pressure. So this is what it means. Okay, so from top till the base, these are the west zones of the lungs. Okay, please remember this. Then coming to V by Q mismatch, so ventilation perfusion mismatch. So by seeing this ventilation perfusion mismatch, we can decide what kind of block that is happening. Okay, if it is 0, V by Q is 0, that means that the volume is low, meaning so there is no volume filling that is happening. The perfusion is normal, but there is something blocking the respiration. So that means there is some foreign body or some pneumonia that is blocking the airflow through the respiratory or the conducting zone. So that is what V by Q 0 means. Okay, V by Q infinity means there is some perfusion loss. Okay, Q will be 0. Okay, so perfusion, there is no perfusion at all happening near the alveoli. So this is what V by Q infinity means. Okay, it leads to the pathology will be the pulmonary embolism. So pulmonary embolism means there won't be any perfusion, right? So that is where the V by Q will be infinite. Okay, so that's it. Then coming to A by A gradient. So basically, to determine the type of hypoxemia that is going on, we are taking something known as A by A gradient. Okay, so normally the A by A gradient will be 5 to 15 mmHg. Okay, So this is the alveolar to arterial SpO2 value, that is the A by A gradient. Okay, the pressure that is there in the alveoli to arterial zone. Okay, so what happens in hypoventilation or high altitude is there is a reduced that is alveolar pressure is reduced because there is no enough air to be breathing, right? So A will be reduced. So that is why, so the small a will also be reduced because there is no enough oxygen, alveolar oxygen. So that is why even the small a will be reduced. So that is why A by A will be normal. Okay, when there is hypoventilation or high altitude. Whereas if there is V by Q infinity, that is some pulmonary embolism, or if there is some pneumonia, what happens is there is enough A. Okay, so there is enough alveolar oxygen, but whereas but there is not enough arterial oxygen. So it means that A will be increased as compared to small a, right? So this is the gradient with respect to V by Q mismatch or pneumonia. Okay, V by Q infinity or pneumonia. So please remember this A by A gradient. Okay. Then coming to hemoglobin, oxygen, and carbon dioxide relation, we know that, right? The curve. Okay, so the sigmoid curve we have been studying since our first year, right? So this is the oxygen dissociation curve that we have to study. So oxygen dissociation curve, if it is shifting to right side, it tells that there is reduced affinity for oxygen, whereas if it shifts to the left side, it means that there is increased affinity towards the to oxygen. Okay, so right shift means it is near the tissues, whereas if it is in the alveoli or the lungs, it is going to be on the left side. Okay, so this is the oxygen dissociation curve. Then, so let us see some of the laws that are with respect to the shift that happens. So that is chloride shift. Okay, this is also called as Hamburg's phenomenon, where, so basically carbon dioxide is carried as bicarbonate, right? So all the if bicarbonate is too much, so it has to have a too much weight. So that is why what happens is bicarbonate moves out. Okay, and chloride comes in. So to replace the negative value from the bicarbonate, there is chloride shift that is happening inside the RBC. Okay, so to remove the bicarbonate. Okay, so this chloride shift is known as Hamburg's phenomenon. Okay, and then there is Haldane phenomenon and Bohr effect. So in Haldane effect, it is in the high, okay, high above in the lungs. This is happening where there is increased oxygen, right? In lungs there is high level of oxygen. Okay, and there is low level of carbon dioxide. That is why what happens is there is the shift in the from RBC. What happens is the oxygen from the lungs shifts to the RBC, whereas the carbon dioxide from the RBC will shift towards the lungs. Okay, so this is the diffusion that is happening high above in the lungs, whereas in the base, in the tissue, the Bohr effect is happening, where there is so carbon dioxide will move into the RBC, and oxygen will move out of the RBC. So two opposite actions. Okay, this is the thing. Okay, this is basically because of the increased CO2, the pH will increase, and there is low affinity for oxygen. When the pH increases in the body, it will lead to low affinity for oxygen. Please remember this. Okay, and please note that there is something called as 2,3-BPG. Okay, which reduces the affinity for oxygen in the hemoglobin. So this 2,3-BPG is what is used in stored blood for this helps in ready oxygen delivery. Okay, so when there is a reduced affinity for oxygen in the hemoglobin, so it is there will be ready oxygen for delivery, right? So if we can use it in trauma patients and all, if there is a volumic shock and all, so if we use the blood, so this is how 2,3-BPG will help in delivering the oxygen very quickly. Okay, so this is the mainstay of all the physiology and anatomy with respect to pulmonology. Okay, so now we'll move to the respective pathologies with respect to respiratory disorders. Okay, so respiratory disorders can be divided as obstructive and restrictive disorders. Okay, so obstructive disorders are, there is some obstruction in the airway. So basically COPD, bronchiectasis, asthma and CA lung can lead to obstructive disease, whereas in restrictive disease there is some pathology in the parenchyma or the interstitium of the lung. So it is not the airway that is the problem, it is the parenchyma or the interstitium that is the issue. So what are the diseases? So interstitial lung disease, sarcoidosis, cystic fibrosis, pneumoconiosis, all the occupational disorders, then the pleural effusion, pneumothorax and infections. Okay, and also carcinoma of lung. So carcinoma of lung can be both obstructive and restrictive. Okay, so this is the thing. So these are the respiratory disorder classification. Now let us see the obstructive lung disorders. Okay, then we'll go on for restrictive lung disorders. So in obstructive lung diseases, the first thing is COPD. Okay, chronic obstructive pulmonary disease. Okay, so what does that mean? So there is some restriction, I mean there is some obstruction with respect to airway which is causing the issue. Okay, so what are the two types? The diseases with respect to COPD is chronic bronchitis and emphysema. Please remember, bronchiectasis is not a COPD, it is a obstructive lung disorder, but it is not a COPD. Okay, so COPD consists of chronic bronchitis and emphysema. Okay, so it is most commonly, COPD is most commonly associated with tobacco smoking. Okay, so please remember. So now with specifics to chronic bronchitis, what does that mean? So please remember, chronic bronchitis is blue bloaters, whereas emphysema is pink puffers. Okay, so pink puffers meaning, so basically smoking. Okay, so the when we see the body of a emphysema patient, it will be pink. Okay, so that is the thing. Whereas when we see a body of a chronic bronchitis patient, it will be blue bloaters, meaning he will be cyanozed. Okay, so let us see what happens. So criteria is more than 3 months of productive cough will be there in a year, and this will be for more than 2 years. That is how we will be diagnosing. This is the diagnostic criteria for chronic bronchitis. Okay, so the thing is, there will be hypertrophy and hyperplasia in the mucus glands in the bronchi. Okay, so in bronchitis, what happens is all the mucus glands will be hypertrophied and hyperplasia will be there, which will be causing the obstruction here. Okay, because of the inflammation. Okay, so this is chronic bronchitis. Okay, clinical features will be dyspnea, wheeze, crackles, cyanosis, and all will be there. Okay, Reed's index is basically the index that we see the difference between the mucosa. Okay, so between the smooth muscle length and the mucosal layer length. Okay, so we'll take the ratio between these two and we'll do the Reed's index. In Reed's index, it will be more than 50%. If the mucosal layer is more as compared to the smooth muscle layer, it will be the Reed's index, right? So Reed's index will be more than 50% in chronic bronchitis. Okay, then coming to emphysema, I told you, right, it is mostly seen in puffers, that is increased smoking. So the criteria to diagnose is radiological and biopsy. Okay, so based on radiology, the chest x-ray would be barrel shaped chest and Hoover's sign will be there, whereas biopsy is Gold's criteria. Based on Gold's criteria is how we diagnose. You need not know about all these criteria and all. Please remember that is the Gold's criteria that tells whether the emphysema is there or not. Okay, so we'll be diagnosing based on radiology and biopsy. Okay, then coming to pathogenesis, so basically there is alveolar wall destruction because of increased smoking. Okay, and also there is a loss of alpha-1 antitrypsin. Okay, so alpha-1 antitrypsin deficiency is there. Alpha-1 antitrypsin, I told you right in the beginning itself, this protects the mucosa. Okay, so this protects the entire lung, but if there is a deficiency, there might be alveolar wall damage, which leads to increased compliance and reduced recoil. Okay, which will lead to alveolar capillary destruction and also cause diffuse. Okay, so diffusion through the lungs will be lost. Okay, DLCO will be reduced. Okay, so please remember this. In all the obstructive lung diseases, DLCO will be reduced. Okay, So basically what does DLCO mean? It is the diffusion lung capacity for oxygen. Okay. So when there is obstruction and alveolar capillary destruction, how will the oxygen be diffusing into the alveoli, right? So capillary will be destructed, so that is why a DLCO will be reduced. Okay. So this is the thing with emphysema. There are types of emphysema, that is centriacinar and panacinar. Meaning centriacinar means there will be distal sparing of the alveoli, meaning, so if this is the alveoli and this is the conducting zone, so if only the central zone is affected, then it is centriacinar. Okay. If the whole alveoli is affected, then it is going to be panacinar. Okay. So the complete destruction will be there with respect to alveoli. Okay. So this is the emphysema types. Okay. Then moving on to the further thing. So COPD is done. Now let us see about bronchiectasis. Okay. So bronchiectasis is associated with cystic fibrosis. I told you, right? Cystic fibrosis we discussed in biochemistry. That is, the chloride channel is affected. Okay. So there is increased secretion from the increased chloride secretion in the lungs and all. So that is why this is associated with cystic fibrosis. Okay. How do you diagnose is based on the clinical features, that is chronic cough will be there, and the daily purulent sputum will be there. Okay. In copious amount, more than 100 ml of sputum might be there. Okay. So this is how we can diagnose bronchiectasis. Then recurrent or RS infections will be there, because too much sputum is there. It can allow the growth of microbes and dilation. Basically ectasis is dilatation of the bronchioles, right? So that is why too many infections can come in. Okay. Then basically how we confirm is by airway dilation. Okay. So we'll try to dilate the airway and see whether the symptoms improve. So that is how we'll be seeing. Then there will be bronchial thickening. If we take a biopsy of it, so if we take a biopsy of the bronchioles, so it will be dilated. Okay. Or thickened. Okay. So this is the thing with the bronchiectasis. It is also associated with Carter-Jenner syndrome and, as I told, cystic fibrosis. Okay. Then investigations that we do are chest X-ray, HRCT and CT. In chest X-ray, tramp track appearance will be there. In HRCT, signet rings. Okay, signet rings will be there. So this is the thing, pathognomic. Then in CT, it is gonna be tree like buds. Okay, so tree like buds will be there. Okay, so this branching and all will be there. So this is how the CT would look like. Okay. Then coming to management, it is going to be chest physiotherapy. Okay, we are gonna tell them to lie on the prone position, or we'll try to tap the chest and all. Okay, so we will be doing chest physiotherapy. Then antibiotic is amoxiclav, because there is increased amount of RS infection risk is there. So that is why antibiotics can be given, and also mucolytics, because there is enormous amount of mucus that is being generated, right? So to reduce the cough and all, we'll be using mucolytics and to expirate it out. Okay. Then that is about bronchiectasis. Then moving on with obstructive lung disorders. So the other disease is asthma. Okay. So asthma might happen because of extrinsic and intrinsic factors. Okay. So mostly extrinsic factors will be in children and intrinsic factors will be with adults. Okay. So extrinsic factors with respect to children are allergens, atopy and viral infections, whereas in intrinsic, meaning, so if it is an adult who has suddenly developed asthma, means he's been having a Samter's triad. Remember, right? Samter's triad, aspirin, polyp, and asthma. Okay. So aspirin is an associated agent that might cause asthma. So, and polyp might be there. This is the Samter's triad. We had learnt it in ENT, right? So this is the thing with respect to asthma. Okay. How do you diagnose asthma is mainly clinical. Okay. So mainly clinical, then we'll do the spirometry and then we'll be doing some tests. Okay. So please note here that DLCO, that is the lung capacity, the diffusion lung capacity of the lung for oxygen is high in asthma. Okay. Whereas elsewhere in all the obstructive lung diseases that we discussed, it was reduced, right? So because alveolar capillary damage would be there, so that is why the DLCO would be reduced, especially that too in emphysema. Okay, whereas in asthma DLCO will be raised. Okay, please remember this extra edge point. Okay, now coming to clinical diagnosis, the patient would be having dyspnea, cough, wheeze, and tachypnea. Remember, right? Dyspnea in cardiology we discussed. So it is going to be MRC grading that we do, whereas NYHA grading we will be doing for heart related dyspnea. Okay. So basically what we do is all these symptoms will improve with a bronchodilator. Okay. So when we give a bronchodilator, for example, it is salbutamol. So all these symptoms will increase. It will reduce. Okay, so that is when we can clinically diagnose asthma. Okay, coming to spirometry, so basically it improves with bronchodilation. So basically again there the clinical features were improved. Here if I do the bronchodilation and then the spirometry will be normal. So that is how we can diagnose asthma. Okay, then also we can do a methacholine challenge test. Okay, so then diagnose asthma. These are the types and criteria how we can diagnose asthma. Okay, so then let us see the pathogenesis, and so that we can go directly for how the treatment or management of asthma can be done. Okay, so mainly it is a type 1 hypersensitivity reaction where there is hyperplasia and hypertrophy of the smooth muscles of the bronchioles. Okay, so because of this there will be bronchoconstriction. Okay, and which leads to mucus plug and shedding of epithelium. Okay, so mainly pathognomic is Kirschmann spirals. Okay, when the sputum, when we check for sputum, there will be Kirschmann spirals. Okay, spiral like Kirschmann spirals will be there. This is a sputum, and this is how Kirschmann spirals would look like. Okay, so this is very pathognomic to asthma. Okay, so basically bronchoconstriction is there, which will lead to the mucus plug and shedding of epithelium. Okay, so charcoal laden crystals also will be the pathognomic to asthma. Okay, so please remember this is the pathogenesis. Now let us see the deep pathogenesis. So how exactly the inside of the pathogenesis occurs, and also we'll see the targets that we can do with respect to treatment of asthma. Okay, so basically what happens is, this is the first time that is happening. So allergen comes and allergen is there, so humoral immunity pathway is happening. Okay, so humoral immunity pathway is there, so meaning all the antibodies and all are generated by the plasma cells. So IgE is generated because it is allergy, right? We know that, right? Allergy will be E. Okay, so IgE is generated, which will activate the mast cell deposition in the blood. Okay, mast cell will be deposited in the blood. Okay, so now suddenly this was the first time. Okay, first time exposure has happened. This is the thing that happened in our body. No exaggeration, nothing is there. So what happens the next time is, in the second exposure to the same allergen, what happens is these mast cells will rupture. Okay, so when the mast cell rupture, it will release the leukotrienes and the cytokines. Okay, so all the cytokines, interleukins, and the leukotrienes, all will be, everything will be released. Okay, so what this will cause, so if the leukotrienes and the cytokines, all the inflammatory hormones, if they are released, there will be airway spasm, dyspnea, and wheeze. Okay, so suddenly the bronchioles will get constricted because of the inflammation that is happening, and there will be dyspnea and wheezing, right? So this is the thing with the second time exposure. So now the same thing at each level we can target, and we can treat them asthma. Okay, so anti-antibody, that is anti-IgE, that is omalizumab. Okay, so there are new other drugs that have come up now, not only omalizumab. Omalizumab is a very costly drug. It is almost about 30,000 to 50,000 per injection. Okay, so there are other advancements. Okay, please go through it if you are more interested in it. There might be a question from newest advancements with respect to antibodies that are being given for asthma treatment. Okay, so then there is a mast cell stabilizer. Okay, so now see, we told, right, mast cell was what was getting ruptured. Okay, so if we stabilize the mast cell, so asthma might not happen. So that is where ketotifen comes in. Okay, ketotifen is where the mast cell stabilizer is used. Okay, then coming to leukotriene synthesis inhibitor. So basically all these things are leukotriene, is where we are targeting leukotriene, because so now mast cell has ruptured, so leukotrienes is what is getting released, right? So if we target the leukotrienes, either reducing the synthesis, or it might be antagonist to leukotrienes, or if we block the receptors in the lungs, so we can target the leukotrienes, right? So this is how we can do. So synthesis inhibitor is steroids, whereas antagonist to leukotrienes is xalutone, okay, whereas the receptor blocker is montelukast, okay, you know that, right? Montelukast with levocetirizine that we give in cough patients, and wheezing is there, okay, so that is where we use montelukast, okay, drug, okay. This is the main action, that is we are basically reducing the leukotriene, or we are blocking the leukotriene receptors, okay. So this is with respect to montelukast action, okay. Then this is all the prophylaxis treatment if there is a asthma patient that is there, okay. This is the prophylaxis that we can do to avoid all this secondary reaction, okay. Then now coming to definite management, so there is a GINA update that has been that has been done. So in 2025, please remember, this is the mainstay of treatment. All the other treatment that we were doing till date is gone, okay. So please remember, if asthma patient comes to your clinic or a hospital, this is what you are doing. Meaning, if there is a mild to moderate level of asthma, that is if in a single week there is gonna be 1 or 2 times wheeze is there, okay, in a 7-day week. So if there is only 1 or 2 times, in that way we are gonna divide it as mild to moderate case of asthma. So here we are gonna give inhaled corticosteroid, for example budesonide and all these things, and we are gonna add formoterol, okay. You know that, right? There is a there is a inhaler called THORAX and all. It contains, if you have seen the inhaler, it is going to be budesonide with the formoterol. So this is the brand name, okay. So please go, there are many other drugs also, THORAX, okay. So one of the best example I can tell you, THORAX will be having budesonide with the formoterol, okay. So this is the thing with respect to mild to moderate cases, whereas in severe cases it is the same thing, okay. It is going to be high level of inhaled corticosteroid along with formoterol, and we are also going to add LAMA, okay, long acting muscarinic agonist, okay. Long acting muscarinic agonist is what we are going to add, okay. So this is with respect to everyone, for everyone we are going to treat it the same way, okay. Then one more thing, so with the long acting I mean, with the long-term use of inhaled corticosteroid, oral thrush might happen, the candidiasis growth might happen. So this is where we will use clotrimazole mouthwash, okay. Clotrimazole mouthwash can be given. This is an extra edge point, with very important, okay. So this is how we treat asthma, okay. Now, for example, if there is an acute exacerbation case of asthma, so suddenly an asthma patient is coming to your clinic and he is suddenly exacerbated, okay. So now you can't use this ICS formoterol and all. So it is for home, like if it is a home case, so it is how he can treat the asthma with. But now he's in an emergency case. So how will you treat is, first thing is O2, okay. So O2 supplementation is what we do. Then we'll give salbutamol nebulization, okay. So after salbutamol nebulization, we are going for ipratropium bromide, okay. Ipratropium can be given. Then we'll go for corticosteroids. Then after this, after any of this is not working, then we'll go for magnesium sulfate or then we'll go for terbutaline, okay. So this is how you treat an acute exacerbation of asthma. O2, then we'll go for bronchodilation, that is salbutamol. Then we'll go for ipratropium bromide. Then we'll add a corticosteroid as a anti-inflammatory. Okay. So if this doesn't work, then we'll go for the higher level drugs, that is magnesium sulfate and terbutaline. Okay, so this is how you treat a case of asthma. Okay, that is all with respect to all the obstructive lung diseases. Now let us go on to the restrictive lung diseases. Okay, so now let us take a look at the types of restrictive lung disorders. So altered respiratory mechanism lung disorders and diffuse parenchymal lung disorders. Okay, so basically if there is altered respiratory mechanism, so it will be in polio, Guillain-Barré syndrome, and MS, that is multiple sclerosis, ALS, and myasthenia gravis. So here there is a respiratory mechanism that is altered. So this will also lead to restrictive lung disorders. But our focus is on diffuse parenchymal lung disorders, that is pneumoconiosis, all the occupational disorders, then sarcoidosis, pulmonary fibrosis, then ARDS, then pulmonary Langerhans cell histiocytosis. So these are the diffuse parenchymal lung disorders. Okay, here the alveolar diffusion capacity is affected, just like we studied in emphysema. Here the DLCO will be affected and A by A gradient will be increased. Okay, so the reason why A by A gradient is increased is because the ventilation is normal, whereas the arterial conduction or the diffusion capacity is altered. So that is why there is a reduced oxygen that is in the artery. Okay, so in the pulmonary artery, the pulmonary veins, the oxygen levels will be low. So that is why here the A by A levels will be high, whereas here in altered respiratory mechanism, so there is no alteration with respect to the diffusion capacity. The diffusion capacity of oxygen is normal. So that is why A by A will be normal, just like hypoventilation and all we saw it, right? So in the same way here also it will be normal. So this is the thing with respect to restrictive lung disorders. Okay, so now let us see one by one. Okay, so idiopathic pulmonary fibrosis. Okay, it is because of idiopathy. Okay, so nothing, we don't know the etiology. What happens is there will be dyspnea, fatigue, and dry cough. Dyspnea, fatigue, and dry cough, and the crackles will be velcro like. Okay, and we can also see clubbing. Okay, with respect to this idiopathic pulmonary fibrosis. What happens is there is increased risk of smoking and also pollution, and also if there is genetics, this might happen. Okay, so genetic association is there. Then coming to chest x-ray, it looks like a honeycomb. Okay, so this is very pathognomic with respect to idiopathic pulmonary fibrosis. Please take a look at the chest x-ray of a pulmonary fibrosis. It looks just like honeycombing. Okay, honeycombing will be there. So when you see a honeycomb chest x-ray or a CT also exactly looks like honeycomb only. So that is how we will diagnose pulmonary fibrosis. Okay, complications will be, so just like any other fibrosis, it will be pulmonary hypertension, right heart failure might happen, arrhythmias, and respiratory failure might be there. Okay, so this is with respect to pulmonary fibrosis. Now coming on to occupational disorders, the important ones is, please remember, asbestos we will put as sheets, right? So all the sheets and all that we use, asbestos sheets and all, so that will be basically above. So but it will be acting on the below base of the lung. But silicosis will be in the sand ground. Silicons will be in the ground, but it will be affecting the apex. Okay, most commonly. So this is the difference between asbestosis and silicosis. Okay, so now asbestosis, what happens is there is basically calcified pleura will be there. Okay, then plaques will be there. When we take a chest x-ray, there will be plaques that are present. It will be pathognomic. Okay, pathognomic to see on the chest x-ray. Then coming to sputum, it will be golden brown dumbbells. Okay, golden brown dumbbells when we examine the sputum. Okay, so complications will be adenocarcinoma. It can lead to adenocarcinoma of lung and also Kaplan syndrome. Okay, so please remember the adenocarcinoma of lung association with respect to asbestosis. Coming to silicosis, so basically macrophages responds to silica and leads to fibrogenic factor release. Okay, which will lead to fibrosis. Okay, fibrogenic factors will be released by the macrophages, so which will lead to fibrosis. When we take a chest x-ray, eggshell calcifications will be there. So just around the hilum, the eggshell calcifications will be there. Okay, so eggshell calcifications will be there. So this is very pathognomic to silicosis. Okay, complication is same as asbestosis, the adenocarcinoma. Okay, and Kaplan syndrome. Coming to coal workers, in coal workers, so these are miners. Okay, mining workers, silicosis will be there. Then who work in factories of asbestos sheets and all, so asbestosis will be there. Then coming to coal workers, coal field workers, so black lung disease. Coal will be black, right? So it will be black lung disease. It is also called as black lung disease. And anthracosis. Okay, so basically it is called as anthracosis. Then berylliosis will be in the beryllium exposure. What is beryllium exposure? Mainly in the aerospace industry, all the rockets and flight manufacturers. So these factories and all, so is where the berylliosis will occur. Okay, so there will be non-cacheating granuloma, meaning, so cacheating and non-cacheating we had discussed in general pathology, right? So non-cacheating means it is not a microorganism that the granuloma is forming around. Okay, so that is the non-cacheating granuloma. Coming to byssinosis, it is the cotton industry. It is also called as Monday fever. Okay, so in cotton industry working people, it will be byssinosis. Please remember all these names. Okay, then coming to sarcoidosis, basically sarcoidosis is basically non-cacheating granuloma that will be formed. Mostly it will be idiopathic. Okay, it is mostly associated with the various diseases. Okay, so basically non-cacheating granuloma is what we can say with respect to sarcoidosis, most commonly seen in black females. Okay, so this is sarcoidosis. Then coming to ARDS, acute respiratory distress syndrome. So basically alveolar insult is happening because of various causes, various sepsis, various infections and all. This is a complicated case of any lung disorder. Okay, or if for example from somewhere also it can come. For example, there is a pancreatitis that is happening, it might also lead to ARDS. Okay, so basically inflammation is happened in the body, and it is destructing the alveolar cells. Okay, which leads to inflammatory damage of the capillary endothelium, which will cause the leakage. Okay, leakage into the alveoli. So all the fluids will leak into the alveoli because of the endothelium damage. Okay, which will lead to the intrahyaline membrane formation, which will eventually lead to non-cardiogenic pulmonary edema. Okay, pulmonary edema because of it is a non-cardiogenic issue. Okay, so it is not because of right heart failure or the left heart failure that is happening. So it is because of a inflammation that is happening in the body is why we are getting the pulmonary edema. Okay, so how we can differentiate between non-cardiogenic and cardiogenic is, so in cardiogenic pulmonary edema, the PCWP, that is a pulmonary capillary wedge pressure, will be more than 18 mmHg, whereas in non-cardiogenic the PCWP will be less than 18 mmHg. Okay, so there is no issue with the heart, it is the lung that has been the issue here. Okay, so it might complicate into ARDS itself is a complication. This will complicate into pulmonary vascular resistance and hypertension might happen, and there is loss of surfactants in cases of drowning. Okay, in drowning cases, if there is ARDS, the loss of surfactants might be there. So that is where the lung will lose its capacity to do the compliance, right? So this is how the ARDS happens. Okay, so how do we diagnose this? So bilateral lung opacities will be there with respect to ARDS. If you know that, right? Whiteout lungs will be there. Okay, pulmonary edema and all these things will be there with respect to chest x-rays, and respiratory failure might happen within 1 week of ARDS insult. Okay, so respiratory failure might be there. Okay, so we'll discuss more about respiratory failure types and all. So for now, respiratory failure might happen within 1 week. There will be reduced PaO2 by FiO2 ratio. Okay, then coming to symptoms of respiratory failure also might be there. That is what I told you, right? So symptoms of respiratory failure might appear in the beginning, and it might lead to respiratory failure within 1 week. Okay, so then the management is basically mechanical ventilation that we do. So reduced total tidal volume will be there, and increased PEEP is what we do with respect to mechanical ventilator setting. Okay, I'll come back to that later. Okay, so the management of ARDS. Okay, we'll come back to respiratory failure related thing. Okay, now we will go on to pulmonary hypertension, which is a complicated case of ARDS. Okay, it is a complication of any restrictive lung disorder. So normally the pulmonary arterial pressure will be 10 to 20 mmHg. If it is more than 20 mmHg, it is going to be pulmonary arterial hypertension. Okay, so the classification is primary. So basically it is the classification is nothing but the based on etiology. Okay, so primary pulmonary arterial hypertension, and the second one is due to left heart failure. The third one is due to lung disorders. The third one is thromboembolism and other systemic causes is the fifth one. Okay, so let us see one by one. So primary is basically idiopathic connective tissue disorder, something is there. So it will affect the pulmonary artery itself directly. The pulmonary artery is the issue. Okay, so yeah, because of some connective tissue disorder, let us take Marfan's or some other connective tissue disorder with respect to the vessels is what is causing the insult. So this is primary pulmonary arterial hypertension. The management will be basically endothelial receptor antagonists, right? So basically we are targeting the vessels itself. So example is bosentan. Okay, so please remember the example bosentan, or also we can directly go for PDE5 inhibitors, that is sildenafil and all, and cause the dilation of the vessels. Okay, so now coming to due to left heart failure, we studied in cardiology, right? So it is in left heart failure, it might lead to complication of pulmonary hypertension. So meaning there is a left ventricular dysfunction and mitral stenosis. All these things might lead to a left heart failure, and due to left heart failure it might lead to pulmonary arterial hypertension. Okay, so here the mainstay of treatment is to reduce the volume overload that is happening in the heart, that is diuretics is what is given. Okay, coming to lung diseases, basically COPD, interstitial lung disease, the fibrosis and all we learned, right? So that is the thing. Here we are going to go for bronchodilators. Okay, so when we give the bronchodilators, so there will be reduced pooling and reduced hypertension that is happening with respect to arteries in the lungs. Okay, then thromboembolism, basically pulmonary embolism. In chronic cases of pulmonary embolism is where we can see because it is a chronic complication of pulmonary embolism. Here what we do is basically treat the pulmonary embolism, basically endarterectomy and angioplasty is what we are going to do. Okay, so please remember the protocol with respect to the management. Okay, so first thing is diuretics, oxygen and anticoagulants which we are going to give. Okay, so then what we do is we'll do some vasoreactive testing so that we can decide what extra drug can be given with respect to the management. Okay, vasoreactivity testing is done, so we can divide. So if we give the drug and if it reacts, it is going to be primary pulmonary arterial hypertension, and we can treat it in that way, or else we are going to go for the issues that is causing the all the underlying issues, all the 2 to 5 we discussed, right? All one is basically pulmonary arterial hypertension because of issue in the vessel, but the 2 to 5 is where we'll target the other underlying cause. So here is what we are testing. Vasoreactivity testing is what is being done. So if the MPAP value is less than 10 mm, it is going to be oral calcium channel blockers which we are going to give. If it is a low risk case, we are going to go for that is endothelium receptor antagonist and a PDE5 one, that is sildenafil is what we are going to give, or else we are going to go for combination therapy of both. Okay, so this is for low risk cases. If it is a high risk case, we are going to go for high dose of the same thing. Okay, so then we are going to go for combination therapy. Then what we are going to do is arterial septostomy, or we are going to do Paul's shunt, or finally we are going to go for lung transplant. Okay, so this is what is done with respect to pulmonary arterial hypertension management. Okay, so this is the protocol that we follow. Okay, now the main thing I wanted to tell you was about the respiratory failure. Okay, so respiratory failure are of 4 types. Okay, so type 1, type 2, type 3 and type 4. Here the type 1 is because of ARDS. We discussed, right? ARDS will lead to respiratory failure, whereas in type 2 it is because of the COPD or central respiratory issue, or because of hypoventilation. If the lungs has failed, this is because of type 2. Okay, so the third type is because of perioperative, because of some operative issue during the surgery. If the lung fails, it is going to be type 3, whereas the cardiogenic shock leading to respiratory failure will be called as type 4. Okay, so each has different management. Okay, so let us see one by one. So here in ARDS, as we have discussed, so A by A ratio will be high. Okay, A by A ratio will be high, whereas in respiratory failure, because it is hypoventilation, right? So that is why A by A will be normal. Okay, so here the DLCO, that is DLCO, diffusion lung capacity, is affected. So that is why A by A ratio is increased with respect to type 1. So that is how we divide which type of respiratory failure the failure is happening. So based on the A by A gradient. Okay, so that is why I told you right in the beginning in the physiology, A by A gradient is very, very important to decide what type of hypoxemia is happening. So if there is a respiratory failure, what type of management we are going to do is based on this only. Okay, so the management is basically CPAP and PEEP. Okay, so basically continuous positive airway pressure is given, and then PEEP is maintained. Okay, so PEEP is what maintains the alveoli opening. So here in ARDS the alveoli is ruined, right? Alveoli is what is affected. It might go under collapse. So to maintain to maintain to not go into collapse is what we give is PEEP. Okay, so it is to open the alveoli. Alveoli has to be kept open through PEEP. Okay, so that is why CPAP and PEEP is used in type 1, whereas in type 2 because of hypoventilation and increased COPD, meaning in COPD, so basically all the air that is there is being trapped, right? All the air that I have breathed has been trapped inside the lungs and conductive and respiratory zone, because there is obstruction to the expiration. So that is why FVV1 will be reduced, right? So there is there is enough PAP. The alveoli is open. Okay, so it is not the alveoli opening that is been problem. Okay, here that is why we use BiPAP. Okay. Okay, BiPAP is what we are using. Okay, then coming to type 3, we are going to do the management by chest physiotherapy, just like we did in bronchiectasis. So then other one is CPAP and PEEP. Here also, because of the failure in here there might be failure of alveoli, that is why we are going to go for CPAP and PEEP, just like in type 1. Whereas in cardiogenic shock, the entire thing will be failed. So that is why we are going to go for mechanical ventilation. Okay, so here we are supposed to intubate. Okay, so in the difference between BiPAP and mechanical ventilation is nothing but here we are going to intubate. Okay, so intubate, and it is completely mechanical. The machine is going to take over the entire breathing. Okay, whereas in BiPAP we'll be using mask. The person will be breathing. Okay, but airway increased, high level of airway, and also to remove the all the contained air that is there inside the lung and conductive zone. It will be through the BiPAP mechanism. So this is the types of ventilators. So now we learned the type of respiratory failures and also the type of ventilators in one single page. Okay, so this is how you can learn. It is very easy. Okay, then coming to pleural effusion and pneumothorax. So let us learn about it. Okay, then coming to pleural effusion, it is the Light's criteria that decides the type of pleural effusion is going on. So based on the three things. Okay, so pleural effusion protein by serum protein level, if it is greater than 0.5, if it is if the pleural fluid LDH to serum LDH level, if it is 0.6, and if the pleural fluid LDH level is greater than 2/3 of the upper limit of the normal. Okay, so this is going to be, if any one of it is satisfied, it means that it is exudative. Okay, meaning, so exudative means, so some infection is there which is causing the pleural protein to be increased as compared to the serum protein, meaning, so the albumin might leak out. Okay, so if there is some exudative or some infection, there is endothelial damage, so which is leaking out the albumin and all the proteins into the pleural fluid. So that means that pleural fluid protein will be high, right, as compared to the serum protein, and also all the LDH is getting leaked out. So that means there will be high LDH as compared to the serum LDH. So this is what it means. Okay, so that is why in exudative, any of this thing, any of one, if it is satisfied, it is going to be exudative. Exudative meaning infectious causes, malignancy, pulmonary embolism, and pancreatitis. So basically infectious causes will cause the exudative, whereas if there is no satisfaction with respect to all these three things, so it is going to be transitive meaning it is going to be just water. Okay, so there is no protein leakage, it is going to be just water. That is in cardiac congestive heart failure, then liver cirrhosis, nephrotic syndrome, and myxedema. Here there is no leakage of proteins, but rather than here there is leakage of fluid that is happening. Okay, so this is with respect to transudative. Okay, what do we do, how do we manage is fluorocentesis. We'll send the samples and we'll manage that particular cause. Okay, so that's it. Okay, then coming to pneumothorax, there are three different types of pneumothorax, that is primary, secondary, and traumatic. Okay, the tension pneumothorax is any of these three, but when there is when the air is trapped inside the lungs itself. Okay, so the any of these three will be the etiological causes. Okay, primary is because of rupture of subpleural bleb or cyst. Okay, there is a bleb or cyst in the pleura, and that would have ruptured and would have caused the pneumothorax. Whereas if there is a lung disease and alveoli has ruptured and all the air that is breathing in is getting trapped in the in between the pleura, so this is what causes the pneumothorax. Okay, secondary pneumothorax. If there is a trauma, there exactly all the air that is from the outside will be trapped inside, right? So this is the trauma pneumothorax. Whereas tension pneumothorax means, so it is any of these three. Okay, any of these three might be the etiology, but if the air is trapped and is unable to exit, then it is called as tension pneumothorax. Okay, that is the thing with respect to tension pneumothorax. So what do we do basically when there is tension pneumothorax is we do needle decompression, right? So needle decompression or aspiration is what we do. Then we'll do ICD. Okay, so we'll see whether we have discussed in general surgery, right? So we'll see whether the patient is stable or unstable. If he is unstable, we are going to go for needle decompression, whereas if it is a stable patient, we are going for ICD. Okay, then high flow oxygen if needed is given. Okay, then please note this auscultation findings. So in pleural effusion and pneumothorax, the bronchial breath sounds will be reduced. Okay, when we auscultate, the bronchial breath sounds will be reduced as there is air in between the air or any effusion in between the lung fields. Okay, whereas in the consolidation, the bronchial sounds will be increased. Okay, because this bronchial sounds will be transmitted through that consolidation. So that is why in consolidation there will be increased breath sounds, whereas in pleural effusion and pneumothorax, this is because it is blocking the basic bronchial airway. So that is why we are not able to hear as much as we will be hearing in normally. Okay, so this is one of the auscultation points I wanted you guys to know. Okay, so then coming to pulmonary embolism, so the classification will be this is a new classification. Okay, so this is high risk, intermediate risk, and low risk. Okay, we previously it used to be mild, moderate, and severe, but now it is going to be high risk, intermediate risk, and low risk. This is a new classification that is being done for pulmonary embolism. Okay, high risk meaning there is shock in the patient, whereas if there is a right ventricular failure, because of that it is pulmonary embolism, then it is going to be intermediate. Whereas if it is a stable patient, then it is going to be pulmonary embolism. It is a low risk pulmonary embolism. Okay, so what are the investigation that we do? ECG, echo, chest X-ray, and CT. Okay, so in ECG, S1Q3T3, you know that, right? S1Q3T3 is very famous with respect to pulmonary embolism. And also please remember, if there is V1 V4 T wave inversion is also gonna be pulmonary embolism. Okay, then coming to echo, there is something known as McConnell sign, meaning there is a right ventricle mid free wall akinesia. Okay, so there will be no movement at all. When we do an echo in the right ventricle, there will be no movement at all, akinesia. Okay, so this is known as McConnell sign. Okay, so this is very pathognomic to pulmonary embolism. Okay, so if they give a video based question for you, it will be easier for you. Just see the right ventricle. If there is no movement at all, then go for pulmonary embolism. They'll give you the clinical scenario also. Just I'm telling the echo thing. Okay, now coming to chest X-ray, there will be Hampton's hump, knuckle sign, and Westermarck sign. Okay, that is very pathognomic to the pulmonary embolism. Okay, Hampton's hump and all will be like a triangle in the chest shadow. There will be shadow. Hampton's hump will be there. Then the knuckle sign will be there. Okay, so knuckle sign will be like this and all. Okay, so then coming to CT, there will be saddle embolism. When we take a CT, if there is a pulmonary artery, there will be saddle embolism. Okay, saddle shaped embolism that will be there. Okay, so this is how you can diagnose pulmonary embolism. Okay, polo mint sign. Okay, just when we see the there is a embolism here, so this is how the polo mint would look like, right? So polo mint sign will be like this. Then how will we manage is based on the Wells score. We also run this in DVT, right, in general surgery. So Wells score is how we based on the Wells score is how we manage pulmonary embolism, whether to give anticoagulants and all, or IVC filters. All these things I have discussed in general surgery. Please go see that video for all the management of pulmonary embolism. So now the main things, that is pneumonia and tuberculosis, the two main infectious causes of restrictive lung disorders, that is pneumonia and TB, will be doing here. Okay, so then that is all. Then the lung cancer. So this is the last topic for thorax, and let us continue with pneumonia. Okay, so pneumonia, TB and lung cancer is the last restrictive lung disorders that we are going to discuss. So now coming to pneumonia, there are two kinds of pneumonia, that is typical pneumonia and atypical pneumonia. Okay, so what does that actually mean? So typical pneumonia is where the lobes, mainly the alveoli, is affected, whereas in atypical pneumonia it is the interstitium, the space that is in between the alveoli is what is getting affected. Okay, so this is the main difference between typical and atypical pneumonia. Okay, so it will be bronchogenic. Okay, so bronchogenic and alveoli. Okay, so and in typical versus atypical, there is also the microorganism difference that is there. Okay, so in typical pneumonia it is the streptococcus pneumoniae, just in the name itself it is there, right? Streptococcus pneumoniae. Okay, so streptococcus pneumoniae, Klebsiella and Legionella is the organism with respect to typical, whereas mycoplasma and Legionella, okay, chlamydophila are the organisms with respect to atypical pneumonia. Okay, so please remember, in Klebsiella pneumonia, it happens in chronic alcoholics, and there is a recurrent the current jelly sputum will be there. Okay, so current jelly sputum is very pathognomic to Klebsiella. We have also discussed this in general microbiology, right? So Klebsiella in chronic alcoholics, it will be most risk. Okay, it is a risk factor. So now coming to the chest X-rays, there will be consolidations with respect to typical pneumonia, whereas there will be bilateral multifocal opacities. Okay, so when we see a chest X-ray, so basically if there is a consolidation, okay, it is going to be typical pneumonia, whereas if in atypical pneumonia there will be multiple opacities. Okay, so but this is how we can diagnose. Just by seeing the X-ray, it is easier for you to recognize it. Okay, so then the progression with respect to typical pneumonia is congestion will happen, then the red hepatization, gray hepatization and resolution. So this is how the progression is there. Please note this down. This is very, very important. Okay, so this is the previous year topic: congestion, red hepatization, gray hepatization, then the resolution. Okay, so then the investigation will be procalcitonin, because it is a infection, right? So procal to determine the bacterial infection. Okay, whether it is a bacterial infection that is happening. So that is how we do the investigation. Then the basic OPD management is amoxiclav. That is what we give for OPD management of typical pneumonia. Then for IP management, it is going to be ceftriaxone. Okay, so for IP management it is going to be ceftriaxone, whereas in coming to atypical pneumonia, so there is acute exacerbation is there, so it is called Hamann-Rich syndrome with respect to atypical pneumonia. Okay, so how we are going to manage? So OPD basis, it is going to be azithromycin and clarithromycin is what we are going to give, and atypical in atypical exacerbation, it is again going to be ceftriaxone and other third generation cephalosporins, and also we are going to give higher level drugs like carbapenems and meropenem and all these things. Okay, so now some extra edge is community acquired, hospital acquired and ventilator associated pneumonia. Community acquired pneumonia, most common is the streptococcus pneumonia. Hospital acquired most commonly is gram negative and also staph aureus, which is gram positive. Okay, Then coming to ventilator associated pneumonia, most common is Acinetobacter. Please remember this Acinetobacter thing. Okay. Then coming to community acquired pneumonia, the treatment is gonna be the same. Okay, so we are gonna give in OPD basis, it is gonna be azithromycin that we give. Okay, so azithromycin is what we give in OPD basis for community acquired pneumonia, and for admitted cases, basically it's a third generation cephalosporin, ceftriaxone and all these things. Okay, in HIV patients we had discussed this, right? HIV patient, so pneumocystis jirovecii can occur. Okay, so this is with respect to community acquired pneumonia. So this is all and everything you need to know with respect to pneumonia and how it can be managed. Okay, so there is the classification. So this is how we divide, how we treat, okay, the pneumonia patient. So based on CURB 65 score. Okay, so this is what decides whether we are going to need a IP admission or ICU admission with respect to pneumonia. Okay, so CURB 65, please remember this score. Okay, so this score is also at the last of this PDF. So basically, if the score is 0 to 1, it is a low risk case, and we are going to treat it as OPD basis, and we are going to give azithromycin 500 mg. Okay, if it is the score is 2, then it is a moderate risk. What we are going to do is we are going to give azithromycin and also ceftriaxone. Okay, in IP, this is the IP management. Okay, but if it is a high risk case, we are going to give azithromycin, ceftriaxone, and also do the ICU admission. So this is how we decide who do we admit for in pneumonia cases. Okay, based on CURB 65 score. Okay, so then coming to pediatrics information about pneumonia, that is IMNCI guidelines, right? The pink, green and yellow. Okay, so the thing is, IMNCI divides the pneumonia as no pneumonia, pneumonia and severe pneumonia. Okay, so in no pneumonia, it is going to be cold, cough or mild fever will be there. Okay, it is considered as no pneumonia, and the treatment will be salbutamol. Okay, just the bronchodilators we are going to give in OPD basis. Okay, now if there is pneumonia, there will be exaggerated respiratory rate and chest indrawing is there. Okay, so chest indrawing is pneumonia, not severe pneumonia. Okay, please remember this. So the management will be OPD basis only. Okay, we are gonna give oral amoxicillin for 5 days, and we'll tell them to follow up after 5 days. Okay, and we'll also explain them the danger signs. Okay, if there is a stridor and all these things, we are gonna tell them and send them home. Okay, so this is with respect to pneumonia, is how we are gonna treat right in OPD. So then if it is a severe pneumonia, so the severe pneumonia case will come with stridor and SpO2 will be less than 95. Okay, so when we do the O2 saturation calculation. So with respect to severe case of pneumonia, we are gonna give the IV antibiotics. We are gonna admit the kid and we are gonna do the IV antibiotics. It is basically ampicillin and gentamicin is the drug of choice with respect to IV antibiotics. Okay, so this is all and everything with respect to pneumonia. Okay, so last but one topic, that is tuberculosis, the most important topic, right? So now we'll be discussing about tuberculosis. Okay, so let us see how the disease progresses. Okay, so there is the person has contracted the mycotuberculosis. So what happens is, after 3 weeks there will be caseating granuloma that happens. Okay, so caseating granuloma, the Gons focus will be there in the lungs, and also there might be lymph nodes in the hilum that are affected. Okay, so together is called as Gon complex. Okay, Gons focus and the lymph node that is affected will be together called as Gons complex. Okay, what happens is, in immunocompromised people, suppose if there is a chronic corticosteroid intake, or in certain AIDS people and all, so what happens is there is immunocompromisation. So what happens is there will be cavity formation which will lead to bronchopneumonia, and also there is a hematogenous spread of the disease that was supposed to be in the cavity itself, but this cavity starts spreading. Okay, so that is when the miliary TB occurs. Okay, so this is the disease progression with respect to tuberculosis. Okay, so how is the patient is going to present with? So there will be hemoptysis, weight loss, and chronic cough and fever will be there with respect to tuberculosis. Okay, so this is how the tuberculosis patient will present with. So let us see the algorithm, how we are going to diagnose and how we are going to treat a TB patient. Okay, so suppose a patient is presumed to be TB. Okay, so with all these symptoms, if a patient comes to you, he is told that he is given the name as presumptive TB case. So what we do is, we'll take the sputum culture and chest x-ray. Okay, so we'll divide it as sputum culture positive and chest x-ray positive, sputum culture positive but chest x-ray negative, sputum culture negative but chest x-ray positive, whereas sputum culture negative and chest x-ray is negative. Okay, so this is how we are going to divide the case of presumptive TB as based on sputum and chest x-ray. So if it is sputum positive, it is considered as microbacterium positive, okay, microbacterial TB positive, whereas if the sputum is negative, it is going to be considered as MTB negative. Okay, so just the consideration is what we are doing, but for all the cases, all these patients, we are going to go for CB-NAT. Okay, cartridge based nucleotide assay. Okay, so is what we are gonna go. Okay, CB-NAT is what we are gonna send the samples for. So now after sending to the CB-NAT, if the results will be positive, it will be considered as MTB positive, microtubercular positive. If it is negative, it will be considered as MTB negative. Okay, so we are gonna refer the patient, okay, so to the higher centers. Okay, but now, so consider the MTB positivity is there. Okay, so what we are going to do is, we are going to test for the first drug. So now the patient is having TB. So now we are going to have, we'll have to start the TB management. So how we are going to start the TB management is, first we are going to see whether the patient is sensitive for rifampicin. Okay, so the sensitivity for rifampicin is tested. Suppose the patient is sensitive, then we'll start the new therapy, that is HRZM. Okay, so it is not the HRZE. Please remember, ethambutol has been removed now. So this is the new guidelines that came up in 2025. Ethambutol is removed, okay, from WHO guidelines with respect to the treatment of TB. The E has been removed. Okay, so this is WHO protocol that we are following. Okay, so HRZM, that is the moxifloxacin which is being added. Okay, so what we are going to do is, HRZM will start. Okay, then we'll send the patient to the patient sample for line probe assay. Okay, so line probe assay we'll send. Okay, so we'll come back to this. So suppose the rifampicin is sensitive, is what we talked about. Suppose if it is resistance, so we are not going to start him on any HRZM, but we are going to send directly for line probe assay. Okay, we'll be sending the sample twice. Okay, so twice is what we are going to send if there is rifampicin resistance TB. Okay, so now suppose the line probe assay results come and it tells that there is isoniazid sensitivity. Okay, so line probe assay is what decides whether the isoniazid resistance is there or not. Okay, first we did for rifampicin, then we are sending for isoniazid. So if H sensitivity is there, then we are continuing the regime. Okay, so there is no change, we are going to continue of the regime. Suppose if there is H resistant, that is isoniazid resistant, that is when we are going to go for RZD, rifampicin, pyrazimide and ethambutol regime, and also we are going to add levofloxacin. Okay, so this is the regime that we are going to go for if it is a H resistant TB. Okay, so, but rifampicin sensitive but H resistant is there, so that is when we'll choose this particular regime. Okay, please remember this. Then coming to, if there is a rifampicin resistance, I told you, right? So we had sent the line probe assay twice, and now we'll be deciding them as whether there is only the rifampicin that is resistant, or it is going to be multi-drug along with rifampicin. Is there is any other drug, either it might be isoniazid, pyrazimide or ethambutol that is resistant, that is known as multi-drug resistant, or whether it is pre-XDR. Okay, pre-XDR meaning even the fluoroquinolone is affected, whereas in XDR, okay, so in XDR So we are gonna see whether even the bidaquilin and the linezolid is also resistant. Okay, I'll come back to this. Please remember, just I'm telling the protocol of it. I'll come back to what is MDR, pre-XDR, XDR. I'll tell you. Okay, so suppose all this thing is there. So then we are gonna choose the short regime and long regime. Okay, so this is how the basic treatment algorithm with respect to TB is what we are gonna follow. Okay. So basically, first we'll see whether the rifampicin resistance is there. So then we are going to send for line probe assay to send to check for isoniazid resistance. So based on sensitivity and resistance between these two things, we are going to give certain regimes. Okay, so that is the basic algorithm. Okay, so now I'm going to tell you, I told you, right, there is a modification that has been with the WHO regarding the treatment of TB. So it is a WHO guidelines, not the NTEP guidelines. Please remember this. This is the WHO guidelines for 2025. Okay. So please remember the old one was HRZD. Okay. So HRZD for 2 months it was given. And then after 2 months, HRE was given. Pyrazamine was stopped, and we start giving the 4-month regime of HRE. So this was the old regime that we used to do. But the new regime is, so we have stopped giving the ethambutol, and rifampicin has been converted into rifapentine. Okay, so two drugs have been removed, that is rifampicin and ethambutol, and it has been replaced by rifapentine and moxifloxacin. Okay, so this have been proven to be better acting on the Mycobacterium tuberculosis. That is why the new change. Okay, so here it is 2 months plus 2 months. Okay, so again here also pyrazamine is released. Removed after 2 months. So basically it was 6 months before, but now it has been reduced to 4 months of treatment. Okay, so the new guidelines. Okay, then the terms with respect to all the drug things I was telling, right? So if it is mono drug resistance, it is going to be either isoniazid, pyrazamide, or the moxifloxacin that is resistant. Okay, if it is polydrug resistant, any two of these drugs, any two will be resistant. Okay, rifampicin resistance is, I told you, right, rifampicin alone will be resistant, whereas MDR, meaning multi-drug resistant, meaning isoniazid along with rifampicin will be resistant. Pre-XDR, meaning isoniazid, rifampicin along with moxifloxacin. XDR TB, meaning isoniazid, rifampicin, moxifloxacin along with bedaquiline or linezolid. Okay, so this is the terms that you will have to remember with respect to all the types of TB. Okay, then finally the regime will be for drug sensitive TB. It is going to be HPZM and HPM. See, forget everything. Please remember this table is what I want to tell. Okay, so this is what we are going to follow. So if drug sensitivity is there is no resistance at all, then we are going to go for 2 months of HPZM, 2 months of HPZ. Okay, if there is a mono drug resistance, then all the other drugs other than leaving that one particular drug that is resistant, and we are gonna add moxifloxacin. Okay, mono drug resistance. If it is a rifampicin resistant TB, we are gonna go for BPALM short regime, that is for 6 to 9 months is what we are gonna go for. BPALM meaning bedaquiline, pretominide, linezolid, and also moxifloxacin. If it is pre-XDR, meaning the moxifloxacin was also resistant, right? So that is why we are going to go for bedaquiline, pretominide, and linezolid. This is for long term, that is 18 to 20 months of regime is what we are gonna go for. Okay, but please remember, in the long regime, so bedaquiline is stopped after 6 months. Okay, so in long regime bedaquiline is stopped after 6 months. So just like we stopped pyrazamide in the drug sensitive TB, right, after 2 months we are going to stop, right? In the same way here bedaquiline is stopped after 6 months of treatment. Okay, so this is all and everything you need to know with respect to TB and how it is managed. Okay, so I have given all the mechanism of actions and all the adverse effects with respect to TB drugs. Please go through this table. This is very important previous year topic. Okay. Now, let me tell about the lung carcinoma, the last topic of the pulmonology, that is lung carcinoma. Okay, so lung carcinoma can be broadly divided into small cell carcinoma and non-small cell carcinoma. Okay, so the clinical features how the lung carcinoma patient might present with is basically cough will be there, hemoptysis will be there. Okay, then there will be some bronchial obstruction. So that is when we'll tell them to take a chest x-ray. Okay, so in chest x-ray we can probably see some mass and all. That is when we'll do the further investigations of CT scan, and we'll tell them to do PET scan if there is any spread of disease and all. We'll do the scanning first, and then we'll tell them to go for bronchogenic, bronchoscopy. Then we'll do the biopsy. Okay, so first we'll be doing all the imaging, and once the imaging we are doing the diagnosis. So after diagnosis based on the imaging, that is when we go for bronchoscopic biopsy. So after bronchoscopic biopsy, we'll finally decide, so this is the type of cancer that he is having, and then we'll go for the management. Okay, so the lung carcinoma, as I told you, can be divided into small cell carcinoma and small cell carcinoma. Okay, small cell carcinoma is also called as oat cell carcinoma. Okay, in non-small cell carcinoma, there are three types, that is adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. The names have been given based on the structure that these cancers will generate from. Okay, so in small cell carcinoma, it is the neuroendocrine cells that are affected. Okay, so there is something called as Kulchitsky cells in the lung. Okay, so these are neuroendocrine cells which will mutate itself and cause the cancer. Okay, so this is the small cell carcinoma. Okay, whereas if it is type 2 pneumocytes, the surfactant producing pneumocytes, right? So if the type 2 pneumocytes is affected, it is going to cause the adenocarcinoma. Whereas the small cell the squamous cell is basically the squamous cells, that is the epithelium from the bronchi. If it is affected, it is going to be the squamous cell carcinoma. Large cell carcinoma is basically undifferentiated cells. Okay, large cell will be like anaplastic carcinoma. Okay, so large cell carcinoma, please remember this. Okay, so here the main risk factor that is there is in smokers, it is going to be small cell, squamous cell, and large cell carcinoma. But if he is a non-smoker and has got a lung carcinoma, please note that it is going to be adenocarcinoma. Okay, so highest risk will be adenocarcinoma in a non-smoker. Okay, so it doesn't mean all the smokers only should get the lung cancer. Even the non-smokers will also get the lung cancer. Okay, so this is how the lung cancers are classified into. So then in small cell carcinoma, please note that it is going to be central. Okay, so central, and here in squamous cell carcinoma also is a central, because the bronchioles is what is getting affected, right? So that is why it will be central. Okay, so hilar mass can be seen with respect to small cell carcinoma, whereas adenocarcinoma and large cell carcinoma will be periphery. Okay, so can you remember this? Okay, yes, C, right? Yes, small cell is central and squamous, yes, C. Okay, so central. Okay, so that is how you can remember. So this is the easier way you can remember. Okay, so then coming to paraneoplastic syndromes, I told you, right? In the chapter of general pathology itself, I told you so that lung carcinomas will generate some paraneoplastic syndromes. So the major paraneoplastic syndromes are with respect to small cell carcinoma, it is going to be Lambert-Eaton syndrome. We had discussed the Lambert-Eaton syndrome in general physiology, right? So Lambert-Eaton syndrome, where the calcium influx is affected in action potential generation. There will be Cushing's syndrome, SIADH will be there, and please note that there will be hyponatremia. Okay, if you are suspecting a case of lung cancer, please also we'll be sending their blood tests and all, right? So if you notice, there will be hyponatremia in small cell carcinoma cases. Okay, so then coming to squamous cell carcinoma, so there will be hypercalcemia. Okay, so there will be hypercalcemia with respect to squamous cell carcinoma. These are the paraneoplastic syndromes. Okay, with respect to large cell carcinoma, there will be increased HCG. Okay, HCG will be raised, so that is why gynecomastia can also be seen with respect to large cell carcinoma. Okay, then coming to the investigations, so I told you, right, all the biopsies and all that we do. So basically low dose CT is done. So biopsy, based on bronchoscopy. So bronchoscopic based biopsy is done in all of these cases. Okay, so how we do the management is, so basically in small cell carcinoma it is very aggressive. Okay, so it is very fast dividing, and small cell carcinoma is very fatal. So the here it is very difficult to do the surgery. There won't be any proper one particular mass. It will be what cell, it is like a miliary TB, it will be spread in the entire lungs. Okay, so mainly central, but it will be spread in the entire lungs around the central. Okay, so it is like a centrifuge. Okay, so it will be spreading, so that is why there is no mass to be removed. So that is why the mainstay of treatment is chemotherapy. Small cell carcinoma has very bad prognosis. Okay, chemotherapy, that is cisplatin, etoposide, platinum based therapy is what we are giving for small cell carcinoma. Whereas in non-small cell carcinoma, the mainstay of management is based on the stages. Okay, here the masses will be there, so that is why we'll be staging the masses and then we'll do the management. So in stage 1 and stage 2 we can do surgery and surgical resection can be done. In stage 3 it can be chemoradiation and immunotherapy, targeted immunotherapy can be given. Whereas in stage 4 it is going to be systemic therapy that we'll be giving. Okay, so this is the entire thing that is with regards to lung carcinoma. Okay, and also one extra edge point, please remember I told you, right, immunotherapy that we do and targeted therapy that we can do with respect to certain cancer, it is the adenocarcinoma because it is associated with KRAS, EGFR and ALK. So that is why we can target this and do the immunotherapy. So this is the complete management and classification of lung carcinoma. Please go through this. Okay, then one more thing is lung sounds. Okay, so lung sounds, so the auscultation thing I was telling, right? So with respect to consolidation and how it is going to be different in pulmonary embolism, pulmonary effusion and pneumothorax. So with respect to lung sounds, so fine crackles, so please remember this at least important thing, fine crackles can be seen in interstitial fibrosis. Okay, interstitial fibrosis we can see fine crackles. Okay, whereas coarse crackles can be seen in bronchiectasis. Bronchiectasis there will be coarse crackles. Bronchial breath sounds we discussed already, right? There will be it is the consolidation or the lobar pneumonia. So consolidation increases the bronchial breath sounds. That is what we discussed, right? So the wheeze we know, right? Asthma and all the obstructive lung diseases might be having wheezing. Okay, so this is the thing with respect to all the crackles and breath sounds that you should be aware of. Okay, so this is all and everything you need to know with respect to pulmonology. Okay, so that is now we are done with thorax. Okay, so all and everything with respect to thorax is done. Now we are moving down to abdomen. Okay, thank you.